Right, cool. So I'm a private practice owner here in the Columbus, Ohio area, and I cater primarily to a more active clientele. So I see a lot of CrossFit athletes. I see a lot of power lifters and a lot of ice hockey players as well. Surprisingly enough, we play hockey in Ohio as well. So in doing so, I've seen a lot of individuals with a lot of different types of hip pain. I grew up playing hockey as well. I played in college and a little bit thereafter, and my hips were a mess throughout the entire process. I was a goaltender, so I didn't do myself any favors. And I also played catcher in baseball, also didn't do myself any favors. So I did all the things that you shouldn't do. I specialized early in my sport. I played the same type of sport, same type of position, and I gave myself all the repetitive stress that I could possibly give my hips. But in doing so, I experienced really good clinical care and really bad clinical care. And that's kind of what drove me towards the PT end of things and what made me focus on the hip itself. So the main focus of today is going to just kind of look at the literature and decision-making regarding FAI and surgical and non-surgical approaches and what is the most beneficial route for most folks. So in starting this, the first thing we need to understand is kind of just how things have progressed over time. So this was actually an article that was written, 6 years ago. So this is a long time ago, but during that time frame, there was an 18-fold increase in FAI surgery from 1999 to 2009. And it's only gotten more significant since then. Only 25% of surgeons at the time were willing to even consider a trial of non-surgical versus surgical treatment for this patient population, whereas only 21% of patients were not willing to. So there's a disconnect between what surgeons were okay with and what patients were looking for. And this kind of comes down to how we treat most orthopedic concerns. So if you go back and you look at subacromial decompression and subacromial impingement, it was the same process. We found this bony thing that shouldn't be there. We think that's the cause of why these people are having their pain. So we think, what's the most logical thing to do? Let's lop that thing off and see what happens. But there's a huge gap between finding that anatomical structure to actually researching whether or not what we're doing actually makes sense. And you'll see that that's kind of playing out in FAI, just like it is or has with subacromial decompression. So speaking to the level of evidence regarding FAI, so as you can see from 2004 all the way until 2016, which is just the range that the study had looked at, there's a significant increase in the number of studies, but there's not a significant increase in the number of randomized controlled trials and well-done systematic reviews. They're mostly case reports, case series, and things of that nature, so pretty low on the evidence totem pole. And that kind of stark increase in studies, and you'll notice a stark increase in surgical procedures as well, that happened around 2004. That's when FAI deformity or bony anomalies were first kind of put into the literature. And after that point, that's where surgeries took off, that's where literature took off, and that's kind of what's pushed us towards where we are today. So once again, looking from 2004 into 2016, so it's a much broader range of dates. There was a 495% increase in hip arthroscopies during that time frame. So there is a huge increase in surgery for these folks. Now, obviously, and as we get into the literature, like some people do need surgery for this condition. One person on this call happened to need surgery for this condition. But there are a large number of individuals that just get pushed in that direction because that's how our healthcare systems tend to push things. And it's not just in the civilian ranks. So if you look at the military healthcare system as well, from 2004 into the early 2010s, the same trend. So the number of surgeries increased and the number of hip-related healthcare costs increased just as much as the surgeries did. So from the point of defining what FAI is, you can see this huge trend in our want and our need to treat it. but how do we define who needs surgery and who doesn't need surgery? So this was a interesting scoping review where they looked into the literature of these surgical studies to see what their criteria was for surgery and how they defined who is pushed in that direction, what types of care was offered alongside or in addition to surgical procedures. So of these, the diagnostic imaging was a criteria in 92% of the studies, with the alpha angle being the most prominent factor. They did use special tests and some range of motion to define who needs surgery, but it was pretty sporadic within the literature. Now, the most concerning thing was that 44% of the studies described some type of failed conservative treatment, whether that be steroid injections, whether that be activity modification, and in only 18% of all these studies, they defined failed physical therapy or at least a trial of physical therapy. And during the full course, we'll talk about how the diagnosis is derived, but it's from looking at a combination of the symptoms, clinical signs, and diagnostic imaging. So we can't just focus all of our eggs in one basket. We need to understand when they're feeling their discomfort, what their functional limitations are, what their clinical presentation looks like, and then what their imaging looks like so that we can define who is actually suffering from FAI syndrome and not from some other type of hip pathology. And this study found that only 56% of surgical studies looked at those factors. They more than likely looked at diagnostic imaging and maybe some subjective reports from their patients. And that kind of is carried on through the rest of the study. So they did find within the criteria that the most prevalent reasoning for surgery was that there was no clinical evidence of inflammatory arthritis, which makes perfect sense. And they used a hip pain greater than 3 months as the criteria as well in about 25% of the studies. As you can see, the most important diagnostic indicator at the bottom here was an injection into the hip, looking at the presence of interarticular pathology or labral damage for the criteria for surgery. And when we look at the symptoms related to those individuals that went down the surgical route, generally speaking, symptomatic hip pain was used as an indicator, activity-related pain. So there were some indications as to the fact that these people had pain, but it wasn't well defined and it wasn't focused on what activities or what movements provoked that pain. And in terms of the special tests that were utilized, they did use the FAIS test and the positive impingement test, which are very, very similar tests, as a criteria for surgery. Now, in the full course, we'll go over kind of the statistical properties around these tests. They're really good at screening, so they have a decent sensitivity, decent negative likelihood ratios. But these tests by themselves don't give us a whole bunch of information. If you did the FAIS test on a group of 10 to 20 people, the vast majority of those people would have discomfort in their hip or groin during that test just because of the position that it puts you in. It doesn't necessarily tell you the structure. It doesn't necessarily tell you that this individual is actually suffering from FAI. So when we look at these studies and we look at the criteria used, we have to take that with a grain of salt because it hasn't necessarily been defined in the literature. Now, going back to the important part, this was another systematic review that looked at a very similar set of studies, and they found that non-surgical treatment was reported in 25% of patients who went on to have FAI surgery. And of those individuals, about 7% had some form of physical therapy, 11% had activity modification, and then NSAIDs and intra-articular injections. So a very small number of conservative measures were used for these folks before they went down the surgical route. And this was another study that was looking primarily at a military patient population. And they had about 1,900 participants. They looked at what type of non-operative management was performed prior to surgery, so that they could define utilization and whether or not we're actually doing what the literature says that we should be doing. And of those almost 1,900 patients, 1,100 did not see a physical therapist or any other healthcare provider, chiropractor, athletic trainer, or otherwise prior to going down the surgical route. And of those that did see a PT, the average number of visits was 2. So I don't know if all of you have treated this patient population, but this isn't the type of injury where you can see somebody once a month for 2 total sessions and have them actually go in the right direction. This is something that takes progressive loading over a long period of time to sustain some form of benefit. So this shows that, number one, people aren't receiving care prior to going down the surgical route. And of those individuals that do go down that route, it is a very, very, very abbreviated trial of physical therapy or conservative management. But most importantly, when we look at the literature, we have to understand what do patients care about? What do they want to get out of surgery? What do they want to get out of conservative care? So for this patient population, when we look at this chart, so it was just kind of a scale looking at whether people cared more about resolving their current pain or worried about preventing future arthritis. And when we look at the distribution of responses, the vast majority of people felt like they want both, right? They want to keep that osteoarthritis out of their life, and they want to improve their current state, which makes perfect sense. If you've ever seen these patients or a patient in general, they want to resolve their pain and they want to prevent it from happening in the future, or they want to prevent it from worsening in the future. So we want to look at what the literature looks like in regards to prevention of arthritis. And then also we want to look at what the literature looks like in terms of improving ADLs, sport performance, return to sport, and all of those factors. And we'll delve into that a little bit next. So when we look at surgery or conservative management, patient expectations are incredibly important. And this slide is going to become even more important when we look at return to sport numbers. So patients were polled as to what they expected after surgery. 92% of them expected improved sports performance, 100% improved ability to exercise, improved ability to attain their athletic potential. And when you look at this list, and when we finally get into the return to sport factors, this will become a lot more important, and we'll have to use that information in order to set the right patient expectations going into surgery or into conservative management as well. So when we look at FAI versus and the impact of osteoarthritis or the prevention of OA, there's been no literature that has established the fact that if we have surgery, we're going to prevent the progression of OA. There has been one study that showed, or a few studies have showed, that CAM morphology increases the likelihood of osteoarthritis down the road. Doesn't necessarily say that if we lop that thing off, it's going to prevent OA progression down the road. Now, when we look at pincer type, which is more focused on the acetabulum, CAM morphology is more focused on the femoral head and neck. When we look at the pincer morphology, there was no association with the development of OA. So if you're going to get FAI, get the acetabular kind. It's a lot nicer to you. So once again, this is another study looking at what increased the likelihood of progression to early osteoarthritic changes in individuals with FAI. And once again, they found that a CAM lesion increased the likelihood of progression to OA by about 2.5 times. And they also found that a positive impingement sign increased the relative risk as well. So looking out for those 2 factors can help in your at least understanding of who could potentially go down the OA route at an early stage. But most importantly, we want to understand, can hip arthroscopy decrease the likelihood of osteoarthritis, at least in the early stages? This was a study of 1,900 participants. It was a cohort study, and they found that 21.9% of individuals had a postoperative clinical diagnosis of hip OA within 2 years. So, and this is after surgery. So of those almost 1,900 patients, almost a quarter of them ended up developing osteoarthritic changes after 2 years. And the mean age of these individuals that were in the study was about 32 years old. So it's a very young cohort of individuals. Whereas this was a study looking at very similar findings. It was a smaller cohort, And they found of the 70 participants in this study, 37% had a post-operative clinical diagnosis of OA within 12 to 24 months. It was a little bit older cohort, and it was a smaller cohort, so that might skew the statistics a little bit. But based on the literature available, the likelihood of developing OA after surgery is somewhere between 20 to 40% of individuals will get to that point within a very short time frame. Whereas we want to understand what happens to those individuals that don't have surgery. This was a smaller study in comparison to the one that had 1,900 participants, but they found that of the 192 participants, 82.3% remained free of clinical diagnosis of hip OA after almost 19 years. Now, I did word this in such a way that it put a more positive light on conservative management. So I was playing with numbers a little bit, but it's about the same proportion of individuals that had surgery that went on to have OA, that in comparison to those that did not have surgery that went on to have OA. And once again, this was a look at an older patient population as well, which would probably skew the numbers more towards OA just in general. So based on the literature that's available, and it's not extensive literature at all. There's just a handful of studies that look at this, but there's not a huge difference between the individuals that have surgery and those that don't when it comes to OA. So if somebody is trying to have this surgery prophylactically because they feel like this is my imaging, I don't want to have OA down the road, we can't as clinicians say that if you have this surgery, you're not going to have osteoarthritis. Now, can it be a part of the decision-making process if there are other issues going on? Sure. But we can't do it solely based on the fact that we're trying to prevent the progression to OA. All right, so we talked about OA a little bit, and like I said, there's not a lot of literature on it, but the literature that has been done well, and it gives us a good basis for our decision making. Now, in addition to that, we want to be able to understand how individuals do in general in regards to their function, their symptoms, and their ability to return to what they want to do after the surgery. And when you look at the statistics, people improve in most cases. They improve with regards to their pain levels, their ability to perform their ADLs, and they do improve a little bit with regards to their sport performance and things of that nature. The unfortunate thing is, we'll get to that. So in addition to this, the return to sport rate is actually pretty good. It's almost 90% when you look at a systematic review, looking at a global cluster of individuals. But, and this is a slide that I was alluding to just a second ago, there's a big difference between getting individuals better and getting them back to normal or back to the activities that they loved. If you look at this bar chart here at the bottom, so this is the Hagos subscale, or Hagos self-reported questionnaire, which is, it's very similar to any questionnaire. So it's going to ask you about your pain levels, it's going to ask you about your symptoms with activity, how it impacts your ADLs, how it impacts your ability to play sports, how it impacts your ability to exercise or be physically active, and so on and so forth. Now, when we look at this chart, it looks at where they were at before, where they're at 3 months, 6 months, and then a year out. And obviously you can see there's a huge improvement from before to 3 months, and then it levels off pretty significantly in all of these charts, except for sport is still trends in the right direction. But if you look at the important area, which is this blank space at the top, that's where people are at 100%. That's where people are at 80% to 100%. And when you look at the sports, physical activity, and quality of life subscales, even after this surgery, people are not necessarily getting to the level that they want to get to perform, to do what they love, and to improve their quality of life. So people get better with this surgery, but it is not the end all be all, and it does not always get people back to where they want to be. Now, take into consideration that this is looking at averages, right? So there are going to be individuals that do worse after surgery. There are going to be individuals that kind of plateau and don't do much better. And then there are going to be people that get back to 100% and they are good to go. So take that into consideration when we look at these studies. Just because the statistics are kind of wishy-washy, it doesn't mean that some people, especially after they've trialed conservative management it doesn't mean that those people can't achieve what they want to afterwards. So, and when we look at return to sport, which I would say is probably one of the most important measures in this patient population, because these are athletes in the vast majority of cases, we want to understand return to sport. So if we look at return to sport as, yes, I returned to sport, or no, I didn't return to sport, the statistics are pretty good in most studies, and this is across the board with hip arthroscopy. You're going to teeter between 85 and 95% of people that are returning to sport. The problem with using that scale is it doesn't say that we're returning to the same sport. It doesn't say that we're returning to the same level of play. It doesn't say that we're returning to the same performance level. And this small study kind of tried to tease that out a little bit. And they broke that yes/no question into a couple different areas. So did you return to the same sport at the same performance level? Did you return to the same sport at a lower performance level? Did you return to a different sport? Did you just blanketly return to that same sport, but we're not looking at performance? And did you return to some type of sport? So when you look at the statistics, and at the very bottom here, this blue part of the chart, that's patient satisfaction. The red part is return to sport percentage. So the very top, individuals that return to the same sport at the same performance level is less than, just barely less than 30%. Now, the satisfaction for that group is almost 100%, which makes perfect sense. But when we look at whether or not somebody returned to any sport, that's 85, 90% of individuals. But if you look at the satisfaction, it's 40%. So understanding that there's a disconnect between what we might read in the literature and what the reality is very important. And this isn't the only study that's looked at this. So this is a larger study looking at about 200 athletes and how they fared after surgery. So of these athletes, 57% returned to pre-injury sport at their pre-injury level, whereas 43% did not return to that pre-injury level. And then in addition to that, when we look at those individuals that failed to return to their pre-injury sport at that pre-injury level, 43% were not engaged in any sport because of hip or groin pain. And then 32% were engaged in another sport due to that same pain. So for these individuals, the most likely reason that they're not playing at the same performance level is because of their hip. Now, you're always going to have individuals that don't return to their sport because of something completely unrelated to their injury. So maybe they were a high school senior and they're just done with sports. Or maybe they lost their passion for sport along the way, or they found another sport or another activity that they wanted to. So that skews the numbers a little bit, but it was still a very small proportion in comparison to those individuals that were limited because of their hip pain. Now, of those athletes that are engaged in that pre-injury sport at the pre-injury level, and we look at performance, 46% had impaired sport participation, which included restricted participation. Impaired sports performance, which included restricted participation. So almost half of them were still limited by their hip, even though they were still able to play at the same level. So they were still able to play on their same team. They were still able to kind of be at that level that they want to, but they were not performing at the level that they needed to in order to progress to that next level. And when we looked back at the patient expectations prior to surgery, the most important things for those individuals was improved sport performance and improved ability to be physically active. And the data that we currently have kind of pushes us in the wrong direction. So when we have those pre-surgery consultations or just general consultations, when you see these patients, you treat these patients, we have to understand that there are limitations to what the surgery brings us. And we have to be realistic with those individuals so they don't go into things with this expectation that they're going to resolve all of their issues. They need to understand what's likely and what's possible. So this was once again another study looking at this same thing. So they looked at return to sport, some performance-based measures, and so on and so forth. they found that only 36.4% of individuals are satisfied with their post-operative physical activity level. So once again, going back to that previous expectation, one of the most important things was being able to improve their physical activity level and being able to be comfortable exercising. And when we look at the statistics related to return to sport here, is very, very similar. So 33% of individuals return to a different sport. 46% return to their same sport, but at a lower performance level. And then only 18% of individuals return to their same sport at the same performance level. So there have been multiple different studies that have looked at the same breakdown of what return to sport is, and they've found very similar findings within each study. And then when we look at performance thereafter, so this was a study that looked at professional hockey players, baseball players, basketball players, and football players. Now, when we look at this data, we need to take into consideration that the NHL season is a whole hell of a lot longer than the NFL season in terms of the number of games played. And the same thing with the MLB. So they play an ungodly amount of games, whereas in the NFL, it's a very small number of games. So that does skew the way that we look at this chart, but it still kind of rings true in terms of our drop off in the number of games played. So when we look at this, it looks at this top red line is one season before surgery versus the average of seasons 2 and 3 after surgery. This blue bar underneath is looking at the season before surgery versus just that season right after surgery. And when we look at this, there is a drop off in games played in the NHL of 18 games and 25 games and all the way down here. And when we look at the NFL, because they have a much shorter season, losing 11 games is significant. Losing 7 games is still significant. That's almost half the season. So understanding that just because they're able to return to sport, which was once again at around that 90% level, it doesn't mean that they're returning to the same level or the same capacity. And that same thing rings true when we look at performance. Same study, same cohort, same return to sport level. And this, they use an algorithm that, let's use the NHL, for example. They took goals, assists, plus minus, minutes played per game, and they put all that into an algorithm to derive their performance level. They did the same thing with goaltenders as well. So looking at goals against, save percentage, so on and so forth, to derive what their performance level is. And when we look at that same kind of distribution of one season before versus the average of 2 and 3, one season before versus that season right after return to sport, there's a drastic drop off in performance, especially within the ice hockey players. And it's not just athletes. So when we look at our combat athletes or our military members, we find the exact same distribution of things. So 75% of individuals return to duty when we look at a systematic review of the literature, whereas only 47% return to duty without limitations. So once again, these individuals are returning to what they want to do at a fairly high level, but they're not returning to the ability at which they want to return to that sport or that work duty, so on and so forth. So we have to take that in consideration when we're setting expectations and understand that there are limitations to surgery. Now, with all this being said, and we kind of alluded to it a little bit, there's not a ton of literature out there looking at outcomes, and especially when we look at outcomes related to conservative and surgical management. There have been 3 major randomized controlled trials that have kind of compared the two, and that's the next step that we're going to go through so we can understand what surgery does, what conservative management does, and what we need to do moving forward so that we can treat these patients appropriately. So this was the first randomized controlled trial. It was about 80 patients, equally divided between the surgery and PT group. In that supervised PT program, it was twice a week for 12 sessions. Surgery, it could literally be whatever the surgeon deemed was appropriate. So it could be related to the acetabulum, it could be a labral repair or debridement, it could be the femur that's being focused on, it could be whatever that surgeon deems to be necessary for that individual patient. And the next study, and we're going to go through the results afterwards. It's just easier to kind of lay out the demographics, and then we'll go into how these look like as a whole between the studies. So this is a much larger study of almost 350 patients, pretty closely evenly divided between surgery and PT. So at the initial assessment, participants received a personalized hip therapy information packet. They then had between 6 and 10 face-to-face contacts with a physiotherapist over 12 to 24 weeks. Some of these contacts were allowed either via telephone or email. So this doesn't mean that they were actually going to formal PT. Doesn't mean that they're actually progressing themselves as they should. And we don't actually know what these patients did because there wasn't those one-on-one eyes on these patients as they were going through the program. And then the next study was of almost 200 patients. They had a maximum of 8 sessions over 5 months of physical therapy with an emphasis on muscle strengthening to improve core stability. They were encouraged to perform exercise at home, but their follow through on that was not tracked. Patients were encouraged to avoid impingement positions. So very minimal number of sessions over a long period of time. And we'll get into the actual bulk of what these programs were afterwards, and there are some issues within that as well. And once again, for the surgical group, whatever that surgeon deemed necessary was performed. And when we look at the results of these studies, the first study, the 24-month follow-up, found that there was a 6.3 point difference on the IHOT-33, which is just another subjective questionnaire similar to the HAGOS. There was a 3.8 point difference on the HOS hip outcome scale ADL, and then HOS sports scale was about 2. But these were not statistically significant. They were very close, but they were not. Then we look at the other studies, the Griffin and colleagues and Palmer and colleagues, the follow-up studies thereafter. They did find a statistical significance trending towards the surgical group. Now, when you look at the difference here, it's 6.8 points with a range of 1.7 to 12. And we look at the bottom here, very small difference between the surgical and non-surgical group. And that's going to be very important when we look at the actual outcomes that they used. So most of these outcomes have a minimal detectable change, or MDIC, of 6 for the IHOT-33, 6 to 12, depending on which study they utilized. And when we look at the change, it is right in the middle of that minimally clinically important difference. So it trended statistically beneficial towards surgery, but was that actually clinically relevant when we look at the statistics and we look at what that number actually means? And the same thing rings true when we look at the HOS ADL subscale. 9, 9, and 8 points is a minimally clinically important difference. And when we look at the difference over here, it's about 10 points here and 4 points here. So right within that same wheelhouse of what maybe is important, but maybe isn't clinically relevant. Now, after looking at the statistics, so once again, it did trend towards surgery, but we have to understand what physical therapy was in these studies. So the first study, the Mansell and colleagues study, was delivered over only 6 weeks with mostly mobility and therapeutic motor control exercises, followed by the Griffin and colleagues study that was an average of 5 sessions over 12 to 24 weeks. Only 66% of participants attended, or almost 70% of participants attended less than 8 sessions, and they were primarily non-functional low-load exercises. So we're looking at clamshells, we're looking at transverse abdominis loading, and things of that nature. Now, when we look at the Palmer study, this was an average of 6 sessions over 5 months, and they didn't include any specifics about the program that was used, but we can probably assume based on what the other studies bulk of their program was. So these aren't individuals that are being pushed. They are working on, important things. They're working on motor control and your tolerance for loading and things of that nature, but these individuals are not being pushed to the point where they're preparing themselves for return to sport or return to physical activity in general. And when we look at these same studies, so we want to think that we're very good at what we do. We want to think that we are treating the patients the way that they should be. And we look at those studies that were being performed and we think, that's not what I do. There's no way that that's all that these patients need. And that's what the issue is with the results of these studies. But when we actually look at the literature regarding what these patients receive in clinical care, this was a study, and it was the same study that was looking at the total utilization of exercise, or the total utilization of PT prior to surgery that we talked about earlier. They found that of the individuals that did receive PT, only 12% had greater than 6 visits that utilized exercise. And exercise was only coded in 52% of the total visits in each individual course of care. So that kind of is consistent with what the literature was used for these randomized controlled trials. So we can't be upset with the fact that that these programs were such low-level programs, because it appears as though that's kind of what happens in clinical care, at least based on this study of 1,900 patients. But don't worry, there is hope. There are studies out there that are helping to trend in the right direction. So this is a study, a pilot randomized controlled trial by Kemp and colleagues that is looking at a higher load program. So individuals in both groups attended 8 sessions over a 12-week period, and they also had 12 weeks of supervised gym visits. So they had PT, and they also were in the gym training. Patients were asked to complete 2 additional unsupervised exercise sessions per week. So it's a very high volume program as well. And the programs consisted of things that are going to get you closer to return to sport. So it is a progressive loading program for the femoroacetabular joint. So there were squats, there were lunges, there were deadlifts, there were all the things that build strength and build capacity. And that's what this patient population needs. And when we look at the results from this study, there was a 27-point increase in the IHOT 33. There was a 22-point increase and a 20-point increase in the HOOS subscales, which is just another subjective questionnaire looking at quality of life and pain. Now, when we compare that to the Palmer, Mansell, and Griffin studies, so if we look at the HOS subscales of 1.7-point improvement, now they did not study that specific subscale in this study. So we have to take that with a grain of salt. But when we look at the Mansell and colleagues, it was a 15-point improvement versus a 27, almost 2 times higher improvement. So when we look at this study that involved progressive loading and involved pushing these patients and involved building tolerance, the outcomes were significantly better. Now, we have to take this with a grain of salt because it is a different cluster of patients, different clinicians, and we don't know the specifics that interact with one versus the other. And this is only looking at PT. It's not looking at surgery in addition to this. There are studies that are using the same protocol to look at surgery versus conservative care, but those studies haven't been released yet and the outcomes haven't been published yet. But we're trending in the right direction. So based on the literature that's available, surgery trends in the right direction in terms of comparing conservative to surgical management, but the programs that were used in these randomized controlled trials did not provide a stimulus that would actually get these patients back to where they would need to be. And that's very obvious when we look at the IHOT 33 improvement in this study then that included those loading strategies. 27 versus 15 versus 14. That's a huge difference from study to study. Now we need to understand, how long do we try, right? We can't just keep muddling in conservative management for months and months and years, because at some point it doesn't make sense to continue down that route, especially when you push yourself hard enough and you've been through a good program and you just haven't gotten the results. So based on this consensus recommendation from a large group of hip experts, they've derived that a 3-month duration is probably the best route to go. And when we look at the Kemp study, this was a 3-month duration program. When we look at the Palmer, Mansell, and Griffin studies, the treatment duration was very, very small in comparison. So not only did this study increase the intensity, it increased the volume of exercise, and it increased the total duration of treatment. So that 3-month guideline, based on the literature that's available, is probably a fair place to be. And that's teased out in this very similar study that was also done by Kemp and colleagues. It was done prior to the randomized control trial that we just went through. They found the duration of interventions range from 3 weeks to 5 months when we look at physiotherapist-led interventions for hip-related pain. And they found that interventions of 3 months in duration that included targeted strengthening showed moderate effect size for function. Interventions of shorter duration, 6 to 8 weeks, showed no significant difference between groups. So once again, understanding that longer duration conservative management is likely in our patient's best interest. But seeing that 3-month time frame is very important, because when we get beyond that and our patient isn't making progress, there are some studies out there that show that prognosis when individuals have been symptomatic for a very long period of time can lead to decreased positive outcomes thereafter. So we have to be cognizant of how long we try and be checking outcomes and checking patient tolerance and everything in between as we go along. So in addition to that, we have to understand what patients are comfortable with. Do they want a short trial of conservative management and then right into surgery? Do they want a really long conservative management and then into surgery? Or do they want somewhere in between? Do they want somewhere around that 3-month mark? Based on that similar study that was looking at what patients want out of their treatment, they found that individuals were most comfortable between the 6 to 12-month range in regard to treating their condition conservatively. And that very well puts us in the same range for that 3-month timeline. So patients are comfortable waiting 3+ months. So if your patient is making progressive improvement throughout their plan of care, and you're in that 3 to 6 month phase, there's no reason that you should push them towards surgery if they're making progress, unless that individual patient has other demands. And there are so many factors that go into this decision. It depends on time of year. Is it the off season? It depends on level of play, financial factors. Do they need to play to make money? Like, there are so many factors that go into this decision-making process. But as a whole, patients are okay trialing conservative management for a rather long period of time before going down that surgical route. And when they do go down that surgical route, we need to be understanding who to send them to. Now, I know in Canada, things are a little bit different in terms of how or who you send your patients to. But in the US, we have a lot of autonomy in our ability to push our patients towards one surgeon. And that's very important when we look at the surgeon's career volume and the number of additional surgeries. So this was a study that looked at just that. They looked at how many hip arthroscopies that physician has performed and how many additional surgeries were performed after that initial hip arthroscopy. And once they get into that 1,000+ range in terms of total hip arthroscopies, their additional surgeries thereafter decreases immensely. You don't want to send your patients to somebody that's done 5 surgeries, because the likelihood of them not performing the surgery as well as somebody that's performed it 1,000 times is exponentially prevalent, especially when we look at the literature here. And the same thing is true in terms of career volume as well. The more surgeries that are performed, the less likelihood there is for additional surgeries. The unfortunate thing is when we look at the number of surgeons and the number of total volume of hip arthroscopies, in this one study of looking at New York State, there were only 6 surgeons that had performed more than 500 hip arthroscopies. There were 250 that had performed 0 to 97. So there are a lot of surgeons out there that will perform these surgeries, but there are not a lot of surgeons out there that specialize in this area. Try to find that person, lean on that person, and make it a cohesive effort between conservative management and surgical management. When they get to that point, you need to have that right surgeon to send your patients to. And this is looking at a very similar concept. This is total time in the room for surgeons with a lot of experience and surgeons with not very much experience. So if somebody is doing their first case of hip arthroscopy, the total room time is significantly higher than somebody that's performed 225 different cases. And as we can assume, the longer you're in the room, the more likelihood there is for infection, the more likelihood there is for inefficiencies and things of that nature. So understanding that if you're going to send somebody towards a surgeon, they need to be somebody experienced in hip pain and experienced in hip arthroscopy, or you're not necessarily setting your patient up for success. So as a kind of broad recap, and we went through a lot of literature today, we need to understand what our expectations are. So understanding that when we look at the literature, return to sport is not perfect. These individuals will return to a sport, but it's unlikely that every patient is going to return to their same level or above. And that's true following surgery or following conservative management. Try to give conservative management at least 3 months of time to give you a real shot at getting this patient pointed in the right direction, and make sure that you are progressively loading these patients. And that is my spiel about Femoroacetabular Impingement Syndrome and how the literature holds up in regard to surgery and conservative management.